On this episode of the Ask Mike Reinold Show, we talk about how to treat acute lumbar radiculopathy.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today.
Everybody, welcome back to the latest episode of the Ask Mike Reinold Show. I'm here up at Champion PT and Performance in Boston with our crew of PTs and strength coaches, some of them at least. I mean, it's not even half nowadays. We have a big team nowadays, but we have a handful joining us today, answering your questions. Anything you want to talk about, sports PT, performance, career advice, anything you want to talk about, we're here for you. Head to mikereinold.com, click on that podcast link, and you can fill out the form to ask us questions that we will answer on a future episode. Let's see, who do we have today? We have Lenny Macrina, Mike Scaduto, Anthony Vedetto, Dave Tilley, Jonah Monlock, and Dan Pope answering your questions. Len, who's asking the questions today from the PT students?
Yeah, we have some amazing PT students from some amazing schools. We have NYU's own Ella Hauser and Devin Limerick, NYU, New York University in New York State. We have Tyler Farr from Pacific University in Pacific, Oregon. What town is it in Oregon? Are you unmuted?
In Hillsboro, Oregon, just west of Portland.
Gotcha. Learning about Oregon. Don't know much about it. Bandon Dunes for those golfers out there.
And how to pronounce it, right? You definitely pronounce
Oregon.
it. Yeah,
Oregon.
I feel like Bostonians pronounce it Oregon.
Until I moved to Alabama, and then I got harassed. I had to change it.
Yeah, but wait a minute. The country started
and then I took
here.
Advice. Right. Yeah, I know.
I mean,
but Oregonians say Oregon, which is right.
But the country started here. I mean, however we say it, could be the way it's right. It's said. I mean, we started. Exactly. I don't know. It seems weird. It seems like the timeline's off. But anyway, all right. What do we have? Ella, are you up right now? We need to hear some Ella. We need Ella in our lives.
Ella.
All right, here we go. Tom from Massachusetts says, one injury I tend to struggle with the most is someone with acute lumbar radiculopathy. They often have low back pain, poor movement, and a neurological zing down their leg. Some even have a shifted posture. What are your tips for getting them out of acute symptoms?
Great question, Tom. You know what? I actually like how Tom really focused this one too for us a little bit on getting them out of their acute symptoms. Because, I've seen this range, right? I've seen this range from just moist heat and e-stim to, doing too much activity, and, flaring it up more and more. So I think this will be a good episode just to get kind of some tips on what we do. Who wants to start? Dave, I know Dave loves low backs. Exactly. None of us really like low backs. Neither does Tom.
I actually, ironically, was telling someone last week that I enjoy treating low back because when you find something that's really useful for someone, they're extremely grateful. And I don't know, we work with a lot of athletes. That's great. I love that. But also not being able to pick your daughter up because your back hurts so bad has definitely got to suck. So it's rewarding to help them. But I'll try to make it brief and let other people jump in. But I don't know. I find personally that a lot of times low back pain is a lot less things, but done consistently is really the key. So in my opinion, when we see people maybe given our settings is we're probably the first people to really listen to their entire story and try to understand how they got to us. I think a lot of times they go to the ER, or they go to a physician's office, and no shade, of course, but they get 7 minutes and they get given drugs. I think actually, ironically, someone I'm treating right now, she got 30 oxys at the ER, and then was told to go home and rest, and then go to PT eventually. And she was like, I have no idea why my back hurts. She literally just got a ton of drugs. So. Wow. I think taking the time to listen to what makes it better, worse, how did it start, how did it come on, are there positions that if you do those for a long time, it makes them really bad. I think that's really important because you're trying to find a directional preference is really the key to this, right? There's obviously more athletic people have extension rotation based back pain, but the average person tends to have more flexion rotation or compression intolerant back pain. So you're trying to tease out, what are the things that make them worse and better. And some people, I think, it's not worth diving down the rabbit holes of pain science versus biomechanics, but I've taken those courses and 80%, 85% of their concepts overlap. And it's really about the delivery for the person in front of you. You get someone who's really high level, really athletic. The rapport and relationship with them is going to go better if you use more biomechanical stuff and you kind of explain more the physics of back pain. Whereas someone who is really terrified of their back and they're really scared, they don't really want to hear about their MRIs and the things that are going on. It's better to avoid those terms. But you explain why their back hurts because there's probably certain positions or postures that they do more often that are sensitizing things. And then there's certain positions or postures they're not doing throughout their daily life. Most people aren't lying on their stomach a lot or back bending a lot or, doing limbo contests. And so they don't really have any extension in their back at all throughout their day, but they do sit a lot. They drive to work. They tend to deadlift in their workouts. They have a lot of things that maybe do put flexion forces on their back. So you're trying to educate them on like, hey, listen, you have some positions or postures that are maybe not as comfortable right now and some that are really more. We want to essentially double down the things to help you. And I think that's honestly half the battle is listening to them and giving them education on like the things that are in their daily life that are probably provocative. If they wake up and do a bunch of work at home, they drive to their office, they sit all day at meetings, they go home, they drive to the gym, they skip their warm up and they do some deadlifting. Like that's 80% of people I've treated in the adult population for flexion intolerant back pain. So let's sit on a hard chair when we are at home. Let's avoid deep couches. Let's sit with a lumbar roll when we're driving or at meetings. Let's try to get up and walk around and do some cat cows or press ups throughout the day. Like I think the 23 hours outside the PT is more important than the hour that we give them, to kind of educate them. But of course, manual therapy has a role to then maybe get them more comfortable to exercise more tolerably. If heat and some soft tissue work and dry needling helps their back feel better for a couple hours, they can do more press ups, they can get up on their feet and walk around. Then I think that's kind of our role as like the education and the, kind of like helping them exercise more comfortably. But yeah, so that's kind of the acute case for me. Mostly is like 4 weeks of that, just kind of education. And I see people like once every 2 weeks with like really bad sciatica and they've done just fine.
So I love how you really center that around. It's almost patient education. And think about how many times people just come to you. They have no idea why they hurt. So if they don't know why they hurt, they just know they have the sciatica thing that they've heard about on the internet, right? And if you don't know why, then how are you supposed to have any hope that you're going to get better, right? Like you don't know why. So like how are you going to fix it, right? Like if your sink's leaking and you don't know why, you're just like, oh, my sink's leaking. I don't know, right?
Just to make the analogy is I've said this in the podcast before, but like me and cars, I know literally nothing about my car. I can't change my oil. I literally know nothing. And I have like one mechanic who's local who I go to. Every time I ask him what's wrong and do it, I get the most, like, I feel like I'm at MIT getting the most complex, like engine, like reverse coolant, something. I have no idea what this person's saying. And I'm like nervous about giving them my money. We have a family friend who's a mechanic who like knows that I know nothing about my car and gives me a very simple explanation and why I need to get these parts and get it fixed. I'm like, okay, that makes sense. Like that goes over there. But the same thing happens in PT. We just like throw up tons of these turns on people and they have no idea what discs are and nerve roots and stuff. They have no clue and they get like really overwhelmed.
I feel like you're the guy at Jiffy Lube or Express Oil that takes all the upsells, right? You get
yeah.
New
I have like
wipers,
$1,600 worth of tires now for my oil filter. I have no idea why.
rear differential, like all the just I don't. But it's funny you say that though, but that there's some treatment styles out there within our profession and some of our similar based professions that you could argue are the same thing. They take advantage of you not understanding it, so they throw the kitchen sink at you and charge you for it, right? To try to get that. So I love how this has to center around a bit of the why, and it's kind of funny because you're right. I feel like there's this we have to reconcile this from what we're learning online here, like with like pain science stuff and biomechanics and how that goes together, right? But like man, if you have a neurological thing going down your leg and you have some weakness and stuff, it's definitely more than just oversensitized tissue, right? like this, we're not just talking about pain. Like we're talking actually about some other things that are happening here. Like you have to get down into the weeds a little bit about both biomechanically what that does, but then also what it does do so for psychosocial, right? And I think that's important to kind of put pain science together with biomechanics with that. Otherwise, they're never going to get better. So you have to say like, look, this position, biomechanics, is not a good position for you. You need to get time out of that position, right? Biomechanics, right? But it's not the end of the world if you are in this position, but just realize it's going to continue to keep your symptoms present. You're not going to get better. Pain science, right? It's just like little ways how you like put those two together. But like I think just like everything else. I don't think I've ever said in my career when somebody said, should we do A or B? I say A or B. It's always both, right? With everything we've ever talked about on every episode of this podcast, right? So Dave, I think that's great stuff. Does anybody else want to talk specifically about? So Dave talked about the thought about it. What are some of the things? Let's actually get to the basics. Like, what are some of the things somebody comes into you? What do you do with them in the clinic on the table, right? Dan, you want to jump in?
Yeah, for sure. And obviously, education is a big one. But if you kind of look globally through the research on radicular low back pain specifically, because that is a very specific type of low back pain, you've got a lot of options. And I think it freaks people out, right? So I treat it similarly to other sorts of pain problems, meaning that there's probably a wide variety of exercise that are beneficial for these folks. So things like walking can be helpful, doing basic exercise like cat-cows, doing McKenzie exercises. You can do strength training, right? And you kind of pick whatever works the best and the patient really wants to do, you know? I also find for these folks early on, these are the guys that like limp through the door, right? Or sometimes you see someone come in through like a wheelchair and you're like, what is going on with this person? But they literally hurt so bad that they can't move in bed, they can't stand up. Walking is a huge problem, right? So I think early on, you're trying your best to be creative about what they can do, right? And obviously the soft tissue stuff, like if the modalities, whatever else can be beneficial early on, but I'm also just a big proponent of doing more exercise in positions that feel really good. And I actually have like a list of exercise I'll go through that are based in certain positions. So for instance, supine exercises, prone exercises, sideline exercises, quadruped exercises, standing exercises, seated exercises. If the person feels amazing sitting, but terrible standing, I'm not gonna give them a ton of walking, right? Give them a bunch of sitting exercises, that's fine. If they can't roll around on the floor, I probably shouldn't give them a million core stability exercises because they're going to go from like a plank position to sideline, right, to quadruped, and like their back is just dying, right? So what I tend to focus on early on is getting information about what positions feel terrible, right? Just like Dave was saying. And you can, you know, it's sometimes it'll be crystal clear this person's flexion tolerant or extension tolerant. I usually find that one position is a little worse than another, but we start with the positions that feel really good, right? So a lot of folks are just not going to be able to tolerate laying on their back. It just kind of extends them a little bit too much, right? So maybe we focus more on quadruped exercises because they're going to be in a little bit of a flex posture, or seated exercises. If you're looking for specifics, it's the basics, right? It's things like cat-cows, but maybe not pushing those end ranges that are really aggravated, right? I think McKenzie being something that can be something that's really beneficial. I haven't taken McKenzie courses, so just make sure that you know that when I say these things. But if you look globally on the research about radicular pain, this goes for the neck and the low back, McKenzie is not necessarily needed, right? And it's also not as well studied in this population, which is always interesting to me because what I learned in school is like, oh, radiating pain, McKenzie, radiating pain, McKenzie. And it's really not studied that well. So I don't think you have to push that. And the other thing I will say is that these are interesting injuries for patients because they feel god-awful and it feels like your life is over. And most of these folks go to the emergency room and think something is tremendously wrong. And they just go home a lot of times with some like medications and they're confused, right? They don't know what's going on. And they often will make a really fast reversal. So I think it's also important to educate your patients like, hey, as this resolves, don't be afraid to do more. You may find 2 weeks from now, you're feeling very good or much better from now. So that's a patient education piece, but it also helps guide their own exercise progression. So let's say they're starting with super simple things, they're feeling quite a bit better. The question becomes, hey, can I do more? And the answer is yes, you should be doing more. That's a good thing. So just focus on the basic, easy exercises. You may not feel like you're doing the best job maybe because you're giving them super simple stuff, but gentle motion of the spine, gentle core exercises, nerve glides is another one you can do, walking if they tolerate it well. Focus on the positions that feel really good, and I would do the exercises more frequently if they feel good. A lot of patients will feel better after their exercises, so do it a couple times a day, right? So.
Love it. Love it. What do you think, Len?
I think all great stuff. I'm going to quickly add, and people are going to probably come at me for this, but shocker. Don't be afraid. You guys alluded to medications and drugs. I think the right ones will benefit. So some kind of steroid pack or something. Not that we're prescribing that, but I think having that in our back pocket, don't be afraid to refer out if they're not getting better in the time you think they should, or they're so acutely afraid and in pain that you need help to get them to be able to do PT better. So I think getting them to a doctor, primary care doctor and maybe coaching the patient on what to, the symptoms and what to ask for, or just something of that nature to get them some kind of dose pack or something to alleviate the symptoms, to take the edge off so they can do more. So, drugs can be friendly if they're the right ones and prescribed in the right way. So don't be afraid of that as well.
Love it.
This episode. Epidurals.
This episode brought to you by Merck
Pfizer.
I don't know. I'm happy to jump in on probably like the debatable one here a little bit here too, for the one that people like to talk about here. But Dave and Dan gave the right answers, right? Like in Lenny too, because Lenny likes drugs. So Lenny's older. He's looking for shortcuts. It is what it is, right? That's but no, Dave and Dan gave the right answers in terms of like what we need to do. Here's one thing I want to throw at you too. Do not be afraid to use moist heat and e-stim and soft tissue work and manual therapy on these people to make them feel better. You just gave them a window of opportunity, like Dave said, to potentially now be able to have more movement variability. And then that is going to help them get over this a little bit. But you also just let them get to their son's baseball game and sit in the bleachers, which aren't very comfortable if you're a parent, right? You know these things, right? So like you have to realize here that they're coming to you for many reasons. It's not just to solve their problem or for like the only thing you can do is evidence-based practice. They're coming to you to make them feel better. And don't forget that, right? If you just give them pain science and you just tell them to go walk because it's the only thing in the literature that's shown to be effective, and that person leaves in pain, like that's not that's not a good approach to their daily life, right? So just keep that in mind. You have to combine all these things together. But again, like back to, a couple episodes, like, people feel like shamed if they're, or they're on social media and they say like, oh my God, you used moist heat on somebody? That's crazy. What are you doing? You're wasting time, right? Like you got to realize that you have to put these together and we have a job to do. And sometimes our job is to help neuromodulate their pain so we can get more and have them experience better life and, hopefully get through these symptoms that we do know will be transient at some time, hopefully, right? Makes sense. To me, I think this is a big topic, right? We could go on and on and on with acute lumbar radiculopathy, but I think what we nailed today covered it fairly well, right? It's a ton of education. It's a ton of movement variability, right? And then putting it all together. What I like about this is somebody that I don't want to say the diagnosis, right? But there's a lot of low back pain. You don't know why they have low back pain, right? It's just pain. And then like, there's no radiculopathy. There's no dermatome, myotome, reflex stuff. There's no rotational bias, like you have a stress reaction, anything like that. They just have low back pain. Those are the ones that are tricky. When they actually have radiculopathy down the leg, to me, that's almost a relief because I know what they're dealing with a little bit more. So, keep that in mind. So awesome episode. Thanks so much, Tom. Appreciate it. If you have questions like that, head to mikereinold.com, click on that podcast link and fill out the form. We will answer your questions. Just keep them coming. We'll keep answering them. And please rate and subscribe to us, Apple Podcasts and Spotify, so you get notifications when we have our next episode. Thank you so much.